So we have some good news for you for the next couple of sections. Pancreas, calcium, and thyroid are easy. Because if there's one thing that people have had contact with before, it's diabetes, either in medical school or your own family. There are 10,000 new diabetic patients per week in the United States. So you can guarantee that this is a must-know subject where you have to know every word because it is the plague of our times. Both types of diabetes present with hyperglycemia. The hyperglycemia makes you urinate a lot. See, when you go above the transport maximum for glucose, which is about a blood glucose of 375, you start to spill a lot of glucose into the urine. And that gives you polyuria, urinating a lot. And because you're urinating a lot, you start to get really thirsty. And so high glucose transcends the transport maximum for the kidney, creating polyuria. Now, because of all the sugar, it's a hyperosmolar state. Because high sugar, when it's truly super high, will start to have an effect. Now, not as much as diabetes will when you have a sodium issue. In other words, sodium has more osmolar effect, but when glucose levels are really high, it'll become hyperosmolar. The osmolality changes the size of the lens of your eye. That's why you get blurred vision in diabetes, because when you have all that change in sugar, it actually transforms the shape of the lens in your eye because it can make it shrink and swell and shrink, and therefore diabetes alters lens thickness and alters your ability to see. Mental confusion can happen. Is there any other type of confusion? I suppose so. Maybe there's emotional confusion. Well, mental confusion is because the hyperglycemia makes it so that you can't think well when you have a hyperosmolar state. Lethargy and weakness happen because of all the volume loss and simply the changes in osmolar content. When it's truly, truly severe, you can have a coma. All of this is solved by giving lots of fluids and insulin. Lots of fluids and insulin. It is no surprise to people that type 2 diabetes is far more common. Matter of fact, it's going to be 95 to 97% of cases because type 1 diabetes is not going up, but we are more obese than ever. Because we're more obese than ever, we have much more type 2 diabetes. The other thing is there's much more of a genetic component with type 2 than people realize. In other words, 90% of twins have diabetes if the other twin has diabetes. However, in type 1 diabetes, it's only about half. These are obese people, and the older we get, the more likely you are to have type 2 diabetes. So you have variable degrees of insulin resistance because of variable degrees of obesity. And there is a little bit of impairment of insulin secretion, but that's not the major problem. And there's an abnormally increased hepatic output of glucose. That's part of the reason why it's a disease. Why are you putting out all that glucose when your glucose level is already too high? Type 2 diabetes, the insulin levels are variable because sometimes you actually get so obese that you actually start to become deficient in insulin. However, you also might have tissue resistance provoking an increased level until the pancreas burns out. When the pancreas level burns out, then the insulin level will go down. This is to say that you cannot make a determination of type 2 diabetes by insulin levels. Insulin levels can be up or normal. Insulin levels can't make the diagnosis of diabetes. There is resistance because you don't have enough tyrosine kinase receptors to go around. And when you decrease plasma glucose and insulin and you increase receptor sensitivity, you can. And that's one of the major treatments is to try to resensitize people. In non-obese people, it's usually due to deficient insulin released by the pancreas. This is often the most common mechanism in people who have type 1 diabetes, which is decreased insulin release. Certainly the best initial test for type 2 diabetes is a blood sugar level. You see two fasting sugars greater than 125, which is say 126, a hemoglobin A1C greater than 7%, 6.5% and 7%, and a single glucose above 200 with symptoms. Now, since inactivity and obesity are so much of the cause of this, it can be controlled with diet and exercise in some cases. And patients tend to be ketosis resistant because although there is not a normal amount of insulin or insulin effect, there is still some insulin or some insulin effect. And that's why it's resistant to ketosis, because these are people who have the ability to still have some insulin effect. Now, if ketoacidosis does present, it's from severe stress, like people who have bad infections tend to get diabetic ketoacidosis because infections make cortisol, and cortisol is an anti-insulin. Infections and stress make catecholamines, and catecholamines increase glucose. Corticosteroids increase glucose. Growth hormone increases glucose, and stress hormones function exactly the opposite of people who have insulin. Stress hormones want to raise glucose and free fatty acids, and insulin wants to decrease them. Metabolic syndrome is basically just combining several underlying preventive health medicine disasters, such as atherosclerosis and high lipids, high triglycerides, high glucose, hypertension, central adiposity. Well, why not just say that it's diabetes, hypertension, hyperlipidemia? Well, it is diabetes, hypertension, hyperlipidemia, but we like to give it its own unique name so people feel special. The guy walks into his doctor's office. The guy says, I have some good news and bad news for you. Says, I can't stand anymore, doc. Give me the good news. The doctor says, they're going to name a new disease after you. So the thing is, we've given a name to our disease, metabolic syndrome. It just basically means crescendo evil, diabetes, hypertension, hyperlipidemia, adipose tissue. Now, those are all understandable. It's just a series of lipid problems, atherosclerosis, and blood pressure. However, the prothrombotic state happens because this is always with an inflammatory component. Isn't that interesting? And the clustering of these risk factors increases the probability in a multiplicative way, not just adding up. And that's why metabolic syndrome should be thought of as a separate disease, because it's not just adding up the individual risks, it's actually multiplying them together. That's why metabolic syndrome is more of a risk than just having the diseases individually. Metabolic syndrome is more than just having the diseases individually. Isn't it interesting that type 1 diabetes is less genetically marked than type 2? I think it is, but that's the fact. Type 2 has much more genetic predisposition. So it is, however, a genetic disorder where predisposed individuals have some sort of inflammatory problem. Now, we don't know what it is. We don't have the right inflammatory, and no anti-inflammatory has ever worked. On the other hand, it's the only explanation that seems to make any sense. It's a genetic hypersensitivity. You don't get symptoms of any organ failure at any time until more than 80% of that organ is dead. Your glucose does not go up until 80 to 90% of your pancreas is dead, and the 80 to 90% dead, and then all of a sudden the function changes. That's routine between the pancreas, the liver, and the kidneys. Persons with type 1 diabetes are usually thin, and they have a much earlier onset of action because it is a disease that happens from genetic predisposition. And when you have that genetic predisposition, that is a viral syndrome, you and I might have a virus and have no problem with it. They get type 1 diabetes. It's simply insulin deficiency. Type 2 is resistance. Type 1 is insulin deficiency. This slide will summarize the effects of insulin deficiency on carbohydrates, proteins, and fats. Insulin deficiency, otherwise known as diabetes, leads to an increased blood glucose and increased glycogen breakdown, because remember, glycogen is the storage form of glucose in the liver. And decreased peripheral glucose use because you need insulin to get that sugar into cells. This is the very essence of why you become hyperglycemic in people who have diabetes. You get hyperglycemic. Why? Because you can't get the glucose out of your blood vessels. Protein tends to break down without insulin. Really sophisticated bodybuilders will all know to go get their glucose levels checked so they know how much insulin they need. Because they know that if you take some insulin with your bodybuilding, you tend to get bigger muscles. Protein breakdown does lead to gluconeogenesis, and because it's protein transformation, you get more urea. Now, on terms of fats, without insulin, everybody becomes hyperlipidemic. Without insulin, everybody becomes hyperglycemic and hyperlipidemic. Without insulin, you get more ketones. Without insulin, you get decreased fatty acid synthesis. Without insulin, you get decreased triglyceride synthesis. Do you need insulin to absorb sugar in the proximal tubule? No, you don't. What's the nature of glucose absorption in the proximal tubule? What's it called? Facilitated diffusion, active transport, passive transport. Well, it's a type of facilitated diffusion that goes along a channel. It has sodium that goes with glucose, but you also do need an active transport on the other side of the tubular cell. So it's secondary active transport, and insulin does not affect secondary active transport. Now, what ends up happening is that you lose glucose because the glucose level goes up so high. It's not that you need insulin for secondary active transport. It's just you hit the transport maximum for how much glucose can actually be absorbed. And you lose sodium and potassium along with that. And what ends up happening is that this is what the basis is of the osmotic diuresis of diabetes. Excess glucose sucking all the water out of you. When you have a low insulin level, what happens to your blood potassium levels when you don't have insulin? Blood potassium goes up. The intracellular concentration is low because all the potassium is coming out. Hydrogen ion moves into the cell and pulls potassium out because one cation in, hydrogen, one cation out, potassium. And what happens is that without the insulin, you don't have sodium potassium ATPase pulling the potassium into the cell as much. So the plasma levels end up being increased at the beginning, and then it all gets urinated out. Now the total body potassium is actually low, but the blood level remains abnormally high or normal. So you need insulin to get potassium back into the cell. So sudden insulin replacement, when you give a big squirt of insulin, this is why we can use it therapeutically for hyperkalemia. A lot of insulin will drive potassium into cells, and that's why it can be used for hyperkalemia. What's the effect on sodium of insulin deficiency? Well, polyuria will pull sodium out of the body. Now, the other thing is dehydration keeps it within the normal range because every time you have low body water, that it increases the concentration of sodium. But insulin deficiency makes you dry. Diabetes makes you dry. And you get hyperosmolar as well because of high sugar and because of high triglycerides. So you get high osmolality because of high sugar. Now, the other part about this is that osmolality for most things is 2 times the sodium plus 10. 2 times the sodium plus 10, that's serum osmolality. But if you use and have a very high glucose, when glucose is at exceptionally high amounts, the exceptionally high glucose can result in extra osmotic draw for the body that wasn't supposed to be there. The same thing with a super high urea level, blood urea nitrogen. That also makes extra osmolality, but only at pathologically increased amounts. Hyperosmolar coma is from very severe hyperglycemia. Hyperosmolar coma is when you have such high sugar, it literally dehydrates your brain. And how can anybody think when their brain is dehydrated? The polyuria pulls out all the volume, and you have a huge volume deficit that ends up decreasing plasma and decreasing glucose excretion. And when you have severe loss of fluid, you can actually develop coma because the brain needs normal sodium when it wants to work. Type 2 diabetes presents with the highest plasma glucose and dehydration, but overall, hyperosmolar coma is like marinating your brain in salt. It dries it out. Dried out brains cannot think normally, and that's why massive volume loss results in a hyperosmolar coma. If you have diabetes and you can't get glucose into the cell, what else are the cells going to eat? Well, they'll switch to eating fat. Now, the problem with fat is fat consumption is ketones. So that's one thing. The major reason that DKA gives you a problem with acidosis is because the fat consumption makes ketones. Ketones are acidy. You get an unopposed action of glucagon, and the metabolic acidosis happens because of keto acids. If you don't have insulin, you start to use keto acids to get you into the cell. And you have hydrogen ion secretion because keto acids are called keto acids. They're keto acids. So what ends up happening is that acidosis makes you hyperventilate, and you breathe fast, especially when the pH goes less than 7.2. You breathe fast. However, you still have a metabolic acidosis from hyperosmolar coma. DKA, diabetic ketoacidosis management, is based on giving a ton of fluids and some electrolytes, but specifically electrolytes, we mean potassium. When the potassium level comes down, then we can add the potassium. You use IV insulin because subcutaneous insulin might not be absorbed because there's decreased skin turgor and there's decreased pickup of the insulin from the skin. So IV insulin is used. Low sodium is seen also because for every 100 points above normal, there's a 1.6 drop in the sodium levels, and that's why hyponatremia is common because of high glucose. High glucose lowers sodium levels artificially. For every 100 milligrams elevation in glucose, there's a 1.6 decrease in that sodium level. So why do you get low potassium in DKA? Well, the blood potassium is actually high at the beginning, but the total body potassium is low because when you shift the hydrogen ions into the cell, potassium comes out. Acidosis causes hyperkalemia because the cells suck up the calcium and release the potassium. They suck up the hydrogen ions and release the potassium. And hyperkalemia increases the urinary loss of potassium because hyperkalemia means that we don't want to die, so you start to urinate it out to maintain the body from having a high potassium. So the high potassium will kill you, so we urinate it out. Now the total body is low. This is very difficult for people. How can the blood level be high and the body be low? Very easy. It's like living on your credit cards. We have a high blood potassium. We have a high blood potassium, but the body is actually low. Now, we add potassium to IV fluids when they start to normalize because we know we're expecting a low potassium to develop. Everybody who's got DKA should have a total body depletion of potassium. Did you know that there's more admissions for hypoglycemia in the United States than hyper? I see it all the time. Diabetics overdose with insulin. Is insulin a big protein or a small protein? Insulin is a small protein, so it should freely filter. Insulin is a small protein. Because it's a small protein, it freely filters. And if you have dead kidneys, it accumulates. So that's why everybody who has renal insufficiency from diabetes needs to have their dose of insulin adjusted over time, or they'll all get hypoglycemic by using too much insulin. Type 1 diabetics are more prone to low glucose because not only do they not have glucagon, they also get a lot of exogenous insulin. So the initial symptoms are due to catecholamine release of the hypoglycemia. You become shaky, sweaty, shaky, and then they all resolve by giving the glucose. The whole point about insulinomas is that you have unprovoked hypoglycemia even when you don't know why. You just get high insulin and low glucose levels. And it's the most common of the islet cell supers that hypersecrete insulin, and you become hypoglycemic, confused, headache, disoriented, lightheaded. And it's associated with MEN1 as a syndrome. However, the diagnosis is you've got to see both insulin and C-peptide are up, because remember, only native insulin makes C-peptide. Only your body's own insulin makes C-peptide. The person who has factitious hypoglycemia, the person who's doing it to themselves, the person who's doing it because they're trying to just inject the insulin, would not have a C-peptide up. That's one of the big differences, is that from exogenous insulin, no C-peptide. From insulinoma, yes, C-peptide. The only way to treat an insulinoma is to remove it. That's it. There's no medical therapy for an insulinoma. Now, other endocrinopathies on tumors, gastrinomas, also known as Zollinger-Ellison syndrome, will look for ulcers that are large, recurrent, distal, and multiple. Large and recurrent and distal and multiple. Most ulcers are less than a centimeter. If they're really big, like 2-3 centimeters gastric ulcers, it may be gastrinoma. They're distal. Gastrinomas are distal. What ends up happening is that in a person who has ulcers, just because they have ulcers from like Helicobacter, the ulcers are small, they're proximal, and they go away once you treat the Helicobacter. Glucagonoma is a very rare disease. It's an adenoma of your pancreas. It's making excess glucagon and also raising your glucose and free fatty acids. Somatostatin inhibits everything, and believe it or not, there's actually somatostatinomas. Wow. And vasoactive intestinal peptide causes you to have watery diarrhea and hypokalemia. Watery diarrhea and hypokalemia. All neuroendocrine tumors are scanned and removed. Scan and remove, scan and remove. But remember, never start with the scan in endocrinology. Never start with the scan in endocrinology. You remember the cell that we said makes glucagon, the alpha cell? Well, can you get glucagonoma? Sure you can. And it causes you to have high glucose and diabetes, and it causes you to have high lipids, and just does what glucagon does. What does glucagon do? It raises the sugars and raises free fatty acids, and that's all glucagonoma does. It's an alpha cell oversecretion, you get high sugar and diabetes, and then ultimately you scan it, and what's dead last? Remove it. Remove it. But that's all oversecretions with the exception of prolactin. Prolactin gets bromocriptine, but with the exception of that, never start with scan. This is our final slide in the diabetes and pancreas section. And what we're seeing here is that, diabetes gives you high sugar. Oh my God, it's so amazing. I'm so glad you went to medical school to learn that. And insulinoma, let me guess, gives a high insulin level? I'm a genius, aren't I? Now the difference is, remember that if you're injecting insulin, you won't have C-peptide, because only native insulin has C-peptide. Type 1 diabetes has no insulin. Type 2 diabetes has insulin, but it doesn't have the effect.